Hi, everyone. We're going to get started in just a few minutes. We are going live right now, so I just wanted to let everyone settle in. Welcome to our talk today about EKGs and arrhythmias. You should be able to see my slides. Good morning, Argentina. Advancing forward, very good. We had a little bit of a technical difficulty this morning, so I started the live stream a few minutes early, but it's working now, so yay. And I see we have a lot of people joining us today. Go ahead and say hi in the chat. I see some recurring faces. Good to see you all. And it's 10:30, so let's get started. So thank you for joining us today, you guys. Today is a lecture on cardiology. We're going to go over basics of the EKG and talk about some arrhythmias. My name is Hiva. In case you haven't watched one of my lectures before, I'm a family nurse practitioner, board certified with Archer Review. We do these live webinars, free live webinars for you guys multiple times a week. So we love it when you come and join us. We get a chance to chat about specific topics, then you can ask the questions that you have. We have the lovely Miss Laverta today helping us on the chat, so go ahead and keep your chat box open. If you watched one of my lectures before, you know that I like to keep it interactive, so ask your questions as I'm going through. I'll be asking you my questions, so I want you to try to answer them. Even if you're not confident in the answer, just take a guess. It's going to be more beneficial to you now than waiting till the board. So get it wrong now so you can understand the rationale and get it right on the boards. That's what I always say. So let's get started because we do have a lot to cover. We're going to start with the basics of the EKG. So what I always like to say is for the boards, they're really going to be asking you basic arrhythmia questions. And they just want you to be able to basically recognize it when you see it on your 12 lead and also know what to do about it. So how to manage it. What's the next step? In terms of clinical practice, you're going to want to go a little bit more in depth on your EKG skills because you are going to be getting 12 leads and you don't want to rely on the computer to read your 12 lead EKG. You want to be able to read it yourself confidently, and then you can always look at the computer to see if it's right or wrong, right? Because computers can be wrong. I know that's kind of different in the age of AI, but computers can be wrong, and you want to be able to say, hey, that's not the right reading, right? Because sometimes it can be overread and you don't want to send off red flags if it's overreading. So with that said, what I like to tell you all is if you have the chance, if you're still in clinicals or if you're working as a nurse, play around with the EKG placement if you're not already comfortable with it. You want to know where those 12 leads go and how that looks on a 12 lead report when you get that report. Because oftentimes, if a lead placement is not in the right spot, you can get a really abnormal read on that report, and it's really just due to EKG placement. So you can always just move it around, run it again, and you'll see a normal EKG strip. Why I say that is because, again, you don't want to send off red flags with an inverted T wave, and then it's really just an EKG placement, right? Or like an inverted P wave is what's most likely going to happen, and it's just the EKG placement. So play around with the 12 leads, get to be familiar with where they go and how that looks on an EKG report, and also put them in the wrong spot and see how that changes it. That's going to be kind of fun for you to see. So just a quick recap about the electrical conduction system. You guys are all pretty familiar with this by now, but let's do a quick review just to make sure we're all on the same page as we're starting to read these EKGs. So remember that SA node is going to be that initial impulse that starts it all, right? So it's located in that right atrium. It fires that electrical conduction, and that goes across the right and left atrium, depolarizes those atria, and then allows for that atrial contraction. It slows down a little bit of that AV node, takes a little pause, and then goes down the bundle of His, splits off into that left and right bundle branches, and then helps those ventricles contract or signals those ventricles to contract. So that's the basics of your electrical conduction system. It matters because that's what you're going to see on the EKG report. So again, how does that look on an EKG report? So as that SA node is firing and it's depolarizing that atria, that P wave is that atrial contraction. So that's what you're seeing. And then at the AV node, it's going to go down that bundle of His and then go to the right and left bundle branch block, and those ventricles are going to contract, and that's your QRS, right? And then when the ventricles are repolarizing, relaxing, that's what you're going to see on your T wave. So that's how it translates on the report. Some basic parts of the EKG, so we just mentioned them. You're probably also already familiar with them. You have your P wave, your QRS, and your T wave. It's also really important to note that these blocks mean something. So it's timing, right? And so each one of those little blocks indicates the 0.04 seconds. So 1, 2, 3, 4, 5. So 0.04 times 5 is 0.20. So just know that that's 0.2 seconds is between those bigger red blocks, right? And that's going to help you as you're looking at your PR interval, your QRSs, and your ST segment, because then you can look at the blocks and know if it's within normal or abnormal. So we'll talk a little bit about that as well. But your PR interval is beginning of that P wave to your QRS complex. You have your QRS, and then your ST segment is the end of the S to the beginning of the T. So that's your ST segment. And then you have your QT interval, which is at the Q to the end of the T, your QT segment. So all that is something that you want to get familiar with. So just a quick recap, this slide is really just to illustrate that obviously there are normal ranges for heart rate based on the patient's age. For today's purpose, we're going to be talking about adults, so we're going to consider 60 to 100 normal heart rate, but it illustrates that as a newborn, as you advance through life, that normal range differs, right? So that newborn range is a little bit higher, and then it kind of comes more closer to that adult range by 6 years old. So again, for the purposes of today, we're going to be talking about the normal heart rate for an adult between 60 to 100 beats per minute. Now, when you're looking at 12-lead EKGs, I want you to have a systematic approach, right? So it can be really overwhelming. You look at a 12-lead, you think, oh my gosh, how do I interpret this? And then you default to looking at what the computer interpreted. I don't want you to do that. I want you to come up with a systematic approach of how you're going to look at it the same way each time. That way you know that you're not missing anything, and you feel a little bit more confident that you didn't miss anything, right? So first, this is my systematic approach. You can use this. You can come up with your own as you're practicing. You might come up with your own system, but this is what I do, and this is how I feel more confident going through my 12-lead report. But basically, I look generally, is there anything that's sticking out to me? Is there anything obvious? So general impressions of the EKG. Then you want to calculate your rate and rhythm and make sure all the parts are there. There's a P for every QRS, T wave's not inverted. And then I like to look at my QRS axis, and we'll talk about that, what that means, and how you can look at what's a normal QRS axis and what's abnormal. And then do you see any signs of hypertrophy? You might, right? And that patient who is hypertensive, maybe they're uncontrolled hypertensive, you've been trying to talk to them for a while about starting medication. you might start to see some signs of hypertrophy. And you can point that out to the patient too, right? That's kind of a wake-up call if they're not taking their medication. And then, of course, the big ones you don't want to miss, you want to make sure you catch any signs of ischemia or infarct so that we can intervene early. So again, come up with a systematic approach, and then that way you'll feel confident and you won't miss anything as you're going through that 12 lead. So again, when we start, we want to make sure we're looking at a 6-second strip. So typically on a 12 lead, a 6-second strip is going to be pretty obvious with 2 thicker red lines. You might not see that here, but you can count it out as well. And then again, we want to look to make sure we have the parts, right? So is there a P for every QRS? Is there a T wave? And then let's count the rate, right? So how do you count the rate? There are different ways of counting the rate. What I like to do is count the R to R. So you're not counting each R, you're counting one R to the next R, that's 1, right? So 1, 2, 3, 4, 5, 6, 7, 8. So 8 R to R waves. So 8 times 10, you'll multiply that number by 10. And so the rate on this strip is 80. That's how you calculate the rate. There are a lot of different ways to calculate the rate. This is just the way I like to do it. I find it the most efficient and it's pretty easy to visualize. And then once you've looked at the rate, then you can see, is there a P for every QRS? Is my T wave there? So you can kind of quickly check all that. And then you're going to check your intervals because we'll talk about that in a minute with different arrhythmias. You want to make sure that you're not seeing any changes in those intervals, right? So your PR interval normal should be between 0.12 and 0.2. So again, that's between 3 to 5 boxes, those little boxes. That's another way you can visualize it. So are you seeing that PR interval pretty consistent or is it variable? We'll talk about that when there's different rhythms that you don't want it to be variable, but is it consistently the same PR interval and is it within that normal interval? And then you also want to look at your QRS complex. So this is going to be important in case it's narrow or wide, because you want to make sure that you're not seeing an arrhythmia that's ventricular arrhythmia, right? So we're going to look at our QRS complex and make sure that it's less than 0.12. It's less than the 3 boxes. So we have a narrow QRS complex within normal range. So that's normal. So that's good. And then we're going to calculate our rate again. So look at that R to R. So 1, 2, 3, 4, 5, 6, 7, 8. So that rate is 80, which is within the normal range for an adult. So again, this is going to be a normal sinus rhythm. That's how you're going to look at it. You also, again, want to look at that QT interval. This may come up in the boards because they really want to make sure that you're catching prolonged QT and you're intervening, because the biggest thing they're going to want to know is that, prolonged QT intervals can lead to dangerous arrhythmias like ventricular tachycardia. A type of ventricular tachycardia is torsades de Pointes. So that might come up in your boards. So they just want to make sure that you're looking at the QT interval as well. And that's within normal for gender. So now let's talk about the QRS complex. This one was really intimidating to me when I first started looking at 12 leads. Nobody really talked about QRS complex. I get into clinical practice and be like, oh my gosh, how am I supposed to interpret this? So what I always like to do is visualize what a QRS complex is, and that's why we have these 2 images here for you. So remember, the electrical conduction system of the heart is generally moving towards that left side, and that's what this is demonstrating. So this is how it starts, right? It starts by SA node, and it generally, the electrical conduction system just moves towards that left side. And that's really all the QRS axis is measuring. It just wants you to basically be able to identify, is it moving in the right direction? Or is there something that's maybe causing it to be skewed, moving in the wrong direction? So a normal QRS axis is going to fall within that -30 to 90 degrees. So again, generally to that left side. Remember, the apex of the heart is a little bit tilted to that left. So that's why we give it some leeway between that -30 and 90 degrees. And then abnormal is going to be anything outside that range. So if it's above or I've never seen extreme access deviation, but I guess that could happen. But again, if that were to happen, my first thing would be to check the lead placement and make sure it's correct. And that's how you're going to be identifying that QRS complex. So again, remember with the lead placement, the electrical conduction is moving towards those leads. That's how it picks up on it, right? So you want to look at the lead placement and where it's going. But if you have it moving a little bit more than 90 degrees, you're going to be looking at a right axis deviation. So it's going towards the right side of the heart. If it's above or less than negative 90 degrees, you're looking at left axis deviation. So when would you see this happen in hypertrophy? Remember, there's enlargement of that cardiac muscle, and usually what's happening is that left ventricle is hypertrophy. So those cardiac muscles are getting thicker over time because they're working harder. So when you have hypertrophy, you're going to see axis deviation or displacement towards the hypertrophied side because it's going to take longer for that electrical conduction to go through those myocardial cells, right? And then when you have an infarct, you're going to see the axis pointing away from it. So if you see a right axis deviation, then it might be due to an infarct on that left side. So you might see a little bit of a right axis deviation. So I hope that makes sense. Kind of sit with it, review it. Don't get intimidated by it. It's a lot at first, but it all makes sense eventually, I promise. And then again, with hypertrophy, for the purposes of today, we're not going to go too in depth about hypertrophy, but I want you to know that it's something that you're going to see on an EKG. There are different types of hypertrophy. So atrial enlargement, you can have those atria get really floppy, I guess is a way to say it. It's not really a technical medical term, but it's what we say in practice. So they can get really, those muscles can stretch out and lose that elasticity. And then you can also get ventricular hypertrophy. Again, we talked about that left side, not as much on that right side. So the most common is going to be that left ventricular hypertrophy due to uncontrolled hypertension. That's what you're going to most commonly see. And there's a formula for that if you wanted to calculate that. But again, for purposes of today, just know that that can exist. You can get that hypertrophy of those muscle cells in the heart, and you'll see that on the EKG. With that atrial enlargement, again, I'm not going to go too in depth, but you're going to see the hypertrophy in the P wave. And then with that ventricular hypertrophy, you're going to see it more in that QRS that we talked about. So the big ones you don't want to miss: ischemia, infarct, recognizing the 3I triad is what they call it. So ischemia, injury, infarct. That's why we check the ST segment, right? We look at our T wave, make sure there's no T wave inversions, there's no ST elevation or depression. And then we also look at the Q wave just to make sure it's not wide and deep. And there are different types of Q wave. They're insignificant versus significant Q waves. A significant Q wave usually indicates a current or prior MI, so that might be something you see on the board, so you want to get familiar with that as well. Q waves are considered significant if they're wide and deep. So if they're more than one small square, so more than that 0.04 seconds, or 1/3 of the size of the QRS complex, seen mostly in the chest leads V1 to V3. So again, these are big things we don't want to miss on the boards. They're going to be asking you big things that you don't want to miss. So you don't have to go too in depth about it, but just understand what it is and make sure you can recognize the red flags. So again, systematic approach. Oh, I think this is a repeat of my slides because I was playing around with them. So I'm going to go through. Sorry, I was doing a little playing around this morning. So here we are. We're going to go to the arrhythmias. There we go. So with arrhythmias, again, know the big ones. We're going to start off with something easy. They just want you to know, they want to know, can you recognize it? What are you going to do about it? What's that next step, right? Sinus bradycardia. Again, the biggest thing for this is a rate that's not within that 60 to 100. It's a slow rate. So again, the first thing you're going to do, P for every QRS, there's our T wave. P for every QRS, there's our T wave. P for every QRS. So our parts are there. You're going to look at the PR interval. So is it within the 3 to 5 little blocks? Is it within that 0.12 to 0.20? Is our QRS complex narrow? Yes, it's less than 3 blocks, 3 small blocks. Now let's calculate our rate. So we're going to go R to R as 1. So here's 1, 2, 3, 4. When you get a little more comfortable, this is 4.5. So I would say the rate is about 45 on this 6-second strip, right? So 4 times 4.5 times 10, 45. And so that's definitely a low heart rate, right? So this is sinus bradycardia. With sinus bradycardia, you always want to investigate what's causing it. So it can be normal, it can be abnormal, but you want to not ignore it. It can be normal in someone who's really young, very athletic. If they're on beta blockers, that's kind of their normal. They feel fine. They're not symptomatic. They see a cardiologist. But if it's something that's new, you want to investigate it and make sure it's not something that needs fixing, because sinus bradycardia, low heart rate, can lead to syncope and other red flags. So you just want to make sure that it's investigated before you dismiss it, okay? Sinus tachycardia. So on the other extreme, we're looking at an elevated heart rate. What I want to point out is it's with sinus tachycardia, it's still, the heart rate has to be less than 150. And we'll talk about that when we get to SVT. But with sinus tachycardia, again, you're going to start the same way with this 12 lead as you do with everything else. So look at, there's a P for every QRS. There's our T wave, P, QRS, T wave. And you're going to go through and do that for each one. I'm going a little fast for the purposes of today's lecture, but you'll take your time. That's okay. And then you're going to look at that PR interval. Is it within normal? Yes, with sinus tachycardia, so that PR interval is still normal, right? So that atria is contracting at a normal rate. That's all normal. Your QRS, is it narrow or wide? So that QRS is still narrow, you see? So it's still a supraventricular tachycardia. I'm sorry, it's a supra arrhythmia, supra. So that QRS is above, it's still narrow. So this is arrhythmia is above that AV node. And then now you're going to count the rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You're still not the 6 seconds, so keep going. 11, 12, 13. So 13 times 10, 130. So this heart rate is 130, which is above that normal heart rate for an adult. 60 to 100 is normal. And it's still less than 150. So you can then confidently say, okay, this is sinus tachycardia. Now, remember, again, with sinus tachycardia, it could be normal or abnormal. It can be in a patient who has a fever, is not feeling well. Sometimes you're going to see that tachycardia that's normal, right? The body's fighting off an infection. If they're anxious, if they've had too much caffeine, they're just coming off exercise. Again, all those things can be normal, but you still want to investigate sinus tachycardia because you don't want to ignore it. If you can find an underlying cause and fix the underlying cause, that's the most important, because you don't want them to fall into a dangerous arrhythmia. Like VTAC and VFib, that's going to happen more once they reach a heart rate above 150. But again, you want to investigate what's going on. Why is this patient in sinus tachycardia? Can I safely explain it, or do I need to investigate? And so some of the other issues that can cause sinus tachycardia could be the medications that they're on. Are they being overtreated with a certain medication, like a thyroid medication? I had a patient come in a couple months ago with that issue. She started to notice on her Apple Watch she was becoming sinus tachycardic, and she felt fine, but her heart rate was always within normal range of 60 to 100. And then all of a sudden she noticed she's kind of cruising in that 120, 130 range, even at rest. So it turned out her thyroid medication, she had lost weight and it was too much for her, right? So it was putting her into sinus tachycardia. So you want to investigate what's going on and fix the underlying cause, because you don't want the heart working that hard and risk the patient's health into going into something dangerous. Okay, so again, we're talking about supraventricular arrhythmias, so above the AV node. Now this is the supraventricular tachycardia, SVT for short. People get really confused about this between sinus tachycardia and SVT. Again, SVT is the rate is different. So it's above that 150. So now we are talking about getting into a possible dangerous arrhythmia like VTAC or VFib. So that's why we worry about SVT. Again, you're going to do the same thing when you're looking at SVT, but look, your P and your T waves are kind of blended here, right? Because the rate's so high. So you can't really identify a PR interval Where is your T wave? It's kind of hard to say. And then that QRS is still narrow, so you know it's above the AV node. And then you count the rate. 1, 2, 3, 4, 5, you get it. It's going to be over 150, right? So again, in this patient, you definitely want to fix the underlying cause to prevent them going into a more dangerous arrhythmia. So you want to figure out what's going on. Why are they in SVT? And that might be something that comes up in the boards. So now with your, I think one of the most common ones that you're going to see in primary care practice, atrial fibrillation. You'll have a lot of patients who either know they're an AFib or have a history of AFib. There are two different types of AFib. There's paroxysmal and persistent. So paroxysmal is when a patient goes in and out of AFib. Those patients usually are symptomatic because they're not used to always being in AFib, so they'll feel it. They'll be like, oh, it feels really funny. So they'll kind of go in and out. Some patients aren't symptomatic. They'll just be like, I'll be checking their heart rate. And then if you look on an EKG, they're in AFib, and I'll be like, do you know you're in AFib? They're like, no. So it really depends. Some patients can be symptomatic, some are asymptomatic. But that's paroxysmal when they kind of go in and out of AFib. Persistent is when that patient's consistently in atrial fibrillation. Remember, atrial fibrillation is when you have multiple ectopic atrial spikes. So it's that's why we call it fibrillation. You get that fibrillation on that EKG. In this, the most important thing for atrial fibrillation, this is what the boards is going to want you to know, in that patient, are they being anticoagulated? Because they are going to be at risk for stroke, emboli, because of that disruption of that stasis. The blood is, the stasis of the blood in that atria. They can form a clot, throw a clot, and so you want to make sure you're anticoagulating that patient. So if this patient, if it's a new AFib you're catching, you're going to have to start them on anticoagulation, also rate control them with a beta blocker just to make sure they don't get into a dangerous arrhythmia, and then they'll need further evaluation with a cardiologist to figure out what is the underlying cause of the atrial fibrillation. Is it something that they're going to fix? Is it something where an ablation might help? They want to do maybe a cardioversion. So the cardiologist will figure out different interventions, but if you're the first one catching it, you want to make sure you're anticoagulating that patient and rate controlling them with a beta blocker for their safety. And then if it's someone who already sees a cardiologist and you pick up on the AFib, either paroxysmal or persistent, again, you want to check their med list. Are they being anticoagulated? Are they rate controlled? And you can just write that on your 12-lead report when you're writing your impressions and then signing your name to it so that they know that you did the critical thinking part. You caught that this person's an AFib, but they're being treated appropriately. So now with a flutter, you only have one atrial ectopic focus, but it fires rapidly. So you get that little sawtooth, right? So that's what you're seeing here with that P wave. You're getting multiple P waves firing before that QRS fires. You still have a narrow QRS. So again, we know it's supraventricular because that QRS is narrow. So it's above that AV node, but it's atrial flutter, and that sawtooth is going to be pretty classic, either on EKG or in clinical practice or on the boards. They're going to give you a pretty classical atrial flutter. In clinical practice, you might have multiple atrial flutter happening. That happened to me once, and I learned from our electrophysiology colleagues that you can have two different A flutters going on at the same time, and it'll look a little different. But again, on the boards, they're going to give you that pretty classic sawtooth look on the boards. And again, remember that QRS is narrow. That's how you know it's atrial flutter. It's a supraventricular arrhythmia. Again, the interventions are pretty similar to atrial fibrillation. You just want to make sure that you send them over to our cardiology partners to talk about the different interventions available to them. Okay, that was a lot. So let's see who's with me, who's not. Let's practice with a little practice question. How may you see some of these things pop up on the boards? So here's a question. A 51-year-old patient is taking warfarin, so Coumadin, for atrial fibrillation, and their INR this morning is 2.5. Which of the following is appropriate? So I'll let you read through those options and go ahead and put your guess in the chat. Thank you, Mandeep. Always participating. I really appreciate it. Thank you, Carla. Good job, Mary. I love the participation. Good. So you all got it right. So that's exactly right. So they don't want you to be, experts on managing this patient unless you're working in a Coumadin clinic, but they want you to know the basics, right? So normal therapeutic range for somebody on Coumadin is between 2 to 3. Of course, that's going to be individualized based on the individual patient sometimes. Some cardiologists will go outside that range. But again, for here, they want you to know the basics. This patient doesn't need any further dose adjustment. They're within that therapeutic range for Coumadin. They already told you they were in AFib. How do you manage that patient on Coumadin? Just make sure you understand a normal therapeutic range. Very good. You guys are acing it. I love it. All right, so now we're going to talk about ventricular arrhythmias. So below the AV node and below, right? Ventricular arrhythmias. One of the most common ventricular arrhythmias that you're going to see in clinical practice are what we call PVCs, premature ventricular contractions. So that's going to be these wide. So again, because it's ventricular, it's below the AV node, we're now talking about that QRS complex, right? So you're going to see a wide QRS complex. And so it's going to look extra bizarre. This is pretty classic of a PVC. There's no P wave. It's just, you're going to see that wide and bizarre QRS. For PVCs, it's important to note that they can be normal. When we worry about a PVC is when we have a run of more than 4 PVCs in a rapid succession, because then we worry about that patient turning into a ventricular tachycardia. That's when we worry about it. But if you see a PVC on your EKG here and there, that's normal. Most people do have premature ventricular contractions. Some patients, again, might be symptomatic. They might say, every once in a while, I feel like I have a skipped beat, I have to take a deep breath, and then it goes away on its own, lasts a second, then it's gone. Some patients might not notice it at all. You might just be running a 12 lead for their normal annual exam, and you might catch a PVC, and you can ask them, be like, do you feel funny? They'll be like, no, I feel great. So this is something that you're going to see a lot. Don't be worried about it. Again, if you see a run of PVCs, don't wait till it's a run of 4 or more. If you see a run of PVCs, send them to your cardiology partners to further investigate. They can do an event monitor and see if they're getting runs of PVCs, and then they can tell us if it's concerning or not. But if it's just isolated here and there, that's totally normal, and you can reassure your patients on that as well. So now let's get into the scary tachycardia. So ventricular tachycardia, it might signify coronary artery disease. And so look at that QT interval. If it's prolonged, it can lead to VTAC, torsades. We talked about that. That might be something that comes up in the boards. So you're going to be asking your history questions. And so in this patient, usually with VTAC, and we'll talk about VFib too, you really want to make sure, does that patient have a history of syncope or pre-syncope, right? Have they ever felt like they're going to pass out? Have they ever passed out? What is their family history? Do they have family history of sudden death? And then also looking at their medications that could be putting them at more high risk for having prolonged QT and getting into that dangerous ventricular tachycardia. In this situation, again, you're looking at those wide and bizarre QRS complex. There's no P wave, there's no PR interval. You're just seeing wide, bizarre QRX. This is monomorphic, so they all look the same. You're also going to see polymorphic. That's torsades is more polymorphic, meaning you still see those wide, bizarre QRS complexes, but some are little, some are big, and so it's polymorphic. But again, this is a ventricular tachycardia. The rate is more than 130, and you have no P waves going on. The intervention, you're going to be cardioverting this patient. This is you're going to be starting CPR on them if they're in your office. They're likely not going to be in your office unless you work in tertiary care or emergency medicine. But this is something that the boards wants to make sure you can help prevent by looking at that QT interval and making sure that they're not on medication that puts them at increased risk for prolonged QT. And then, of course, ventricular tachycardia, it's a type of cardiac arrest. So again, hopefully you're not seeing it in your primary care practice. You've probably already initiated CPR at this point if that patient has passed out on you. But basically at this point, the ventricles are not pumping anymore. They're just fibrillating, they're spazzing, they're not filling, they're not pumping, there's no cardiac output. So this is definitely life-threatening, and you want to make sure that you recognize it and you've started CPR, you've initiated CPR in this scenario. Again, hopefully you're preventing it. If a patient comes in talking about a syncopal episode, pre-syncope, you're sending them to cardiology, doing more evaluations to make sure that it's not something that's going to lead to a life-threatening arrhythmia. So now our bundle branch blocks. These ones, we'll start with our left and right bundle branch blocks. So remember, in that conduction system, going to go down the bundle of His, and then it breaks off to that left and right bundle branch block, that left and right bundle branch, and then usually the ventricles contract at the same time. What's happening in a bundle branch block, you have a little bit of a delay in contraction, either in that left side or that right side. So a bundle, it's just caused by a block in that impulse to that branch. So instead of them contracting simultaneously, they're going to contract. You're going to see a little blimp. You're going to see 2 R waves, basically. For your left bundle branch block, you're going to see them mostly in those left chest leads, right? Because it's the left side of the heart. So you're going to see it more in that V5, V6. In your right bundle branch block, you're going to see it more in those right chest leads. So V1, V2. All bundle branch blocks should be investigated if they're new. If it's known, again, you always want to compare a person's 12 lead to their last 12 lead. That's why it's good to get a baseline on your patients at their annual physical starting at a certain age. That's the way I like to practice. But if you find a new bundle branch block, you always want to investigate what's the cause. And left bundle branch blocks are more common. Right bundle branch blocks are not as common and would be a little bit more concerning because, again, you do see that hypertrophy on that left side more with that left ventricle, not as much on the right ventricle. So if I see a right bundle branch block, I'm a little bit more worried because I wonder what's happening on that right side of the heart. Has there been an infarct that's slowing that conduction, right? So again, recognizing that you can have both left and right bundle branch blocks and then investigating the cause. With your first degree heart block, so with this, it's pretty classical. So again, when you see a 12 lead, it kind of, if you're looking at it, general impressions, kind of looks normal, right? No red flags. But then when you look a little bit closer, you're checking for your parts. So there's a P for every QRS, there's a T wave, there's a P for every QRS, but it kind of does look like, the P is a little bit far from the QRS, right? The QRS is narrow. Let's look at that PR interval. So we're counting it and we're seeing that it's more than 0.20. So your PR interval is long. And if you look at all the PR intervals, so again, you want to count all of them to make sure they're all consistently that way. They're not variable because we'll talk about that with our next arrhythmia, but they're all the same. They're all consistently more than 0.20 seconds. Again, your QRS complex is narrow and your rate, you're going to go R to R, 1, 2, 3, 4, 5, 6. So it's 65. So the rate is normal, but it's just that PR interval is prolonged. That's going to be your first degree heart block. So there are different reasons for first degree heart block. Again, you want to see sometimes patients will just be in first degree heart block and it's not concerning, so it doesn't need treatment, but you want to investigate what's causing it and definitely fix the underlying cause if it needs to be fixed. It's not as concerning as this next one, but you do want to investigate what's going on with the first degree heart block. Now, second degree heart block, type 1, there are 2 different types. This is also called Mobitz 1 or Wenke-Bach. I don't know why they name so many different names for the same arrhythmia, but they do. So it can go by all these different names, but it's your second degree heart block, type 1. We're going to do the same thing. We're going to look, again, general impressions, that R wave is not spaced the same, right? So that's interesting. And then you're going to look, there's a P, QRS T wave, T, P, QRS T, P. Where did the QRS go there, right? It dropped. And then again, it picks up P, QRS T, P, QRS T, P, QRS T, P. Where's that QRS? It dropped. And then now we're going to check our interval. So PR interval here could be normal, could be normal. Whoop. It's now prolonged. So it's getting longer and longer, that PR interval, until that QRS drops, right? And then our QRS complex stays narrow. So this is pretty classical of second degree heart block. So the PR interval gets longer and longer and longer until that drops. But your QRS still stays narrow. And then your rate, 1, 2, 3, 4, 5. So your rate can be within the normal, but I worry about the QRSs dropping because it's on the lower end, right? So with this, the patient could be asymptomatic or symptomatic, but you definitely want to make sure you investigate what's going on with this patient, and they probably need to be paced. Again, not something that you would diagnose, but you want to be able to recognize it on a rhythm strip. And then second degree heart block type 2. So this is Mobitz 2. That's the other name for it. For this one, you're going to see there's not a QRS for every P wave, and the PR interval is still within that normal. So look, you're going to, again, general impressions, something's going on. There's no R wave each time. And then let's look at the P wave compared to the QRS. P, QRS T, P, QRS T, P, there's no QRS here, it's dropped, P, QRS T, P, QRS. You're looking at that PR interval and it's not getting prolonged. It's pretty fixed, but sometimes there is a dropped QRS. And then the QRS it looks narrow, it looks wide, but if you look, it's still within that normal range. And then the rate, 1, 2, 3, 4. So definitely not even borderline normal. It's less than normal. You really worry about this patient syncopizing. You want to make sure that you investigate what's going on with this patient, because that low heart rate, you're not getting as much cardiac output. And so they could pass out, faint. It could be bad. So again, with this, you're not getting that prolonged PR interval, but there's a drop QRS. There's not a QRS for every P wave, and the QRS stays narrow. So again, this patient most likely will need to be paced. Most of the time, this is something that's going to be identified after cardiac surgery. That's why we keep patients in the CV ICU for at least 24 hours, just to make sure that we're not looking at an arrhythmia like this. Like oftentimes, if they have an aortic valve replacement, for where that aortic valve sits right on that AV node, sometimes it can cause this conduction issue, and this patient's going to definitely need to be paced so that they don't pass out and syncopize and have go into third degree heart block or complete heart block. But you want to be able to recognize it on the boards. So the difference is there's no prolongation, that PR interval, there's still that drop in that QRS. And so now third degree heart block, this is also known as complete heart block. This is the most concerning. Again, probably not something you're going to see in clinical practice, but something you need to be able to identify on the boards if it comes up. In complete heart block, the atria and the ventricles are just not talking to each other. So if you look, it kind of, you can tell the bradycardia because you don't have enough R to Rs, but let's actually go through it systematically. So here's a P, here's a QRS, maybe that's a T wave. Here's a P, nothing here. Here's a P, QRS, T wave, P, nothing here. And then if you march out to the PR intervals, there is no PR interval because it's variable, right? Some Ps don't have a QRS. And then if you look at the QRS, it's still within normal, so it's not quite wide. So the QRS is looking normal. And then if you march out the P to Ps, they are talking to each other. So if you look, it's equal distance. And oftentimes I like to take a little Post-it note and just do my little lines and just make sure, double check myself, but the P's are marching out. And then you can do the same thing with the R's, right? The R to R's are marching out. They're also equal distance. So the P's are talking to each other. The R's are talking to each other, but the P and the R are not working together. And so that's pretty classic of a third degree heart block. So they're just not talking to each other. And this obviously is very concerning. So again, not something you're going to see in clinical practice, but something you'll probably see on the inpatient side, and definitely need to be treated, definitely need to pace this patient until they can figure out whether they need a permanent pacemaker, what's going on, why are the P waves and QRS complexes, why are the atria and the ventricles not working together, right? Because you worry again about that cardiac output. So a little heart block poem, if you get test anxiety and you're like, I knew all this when I was practicing, but what is it now? It's all escaped your mind. Just go through this little poem with yourself, and then that way you can kind of remind yourself of the different classical signs of the different arrhythmias. But if the R is far from P, then you have a first degree. So remember, you have that prolonged PR interval. It's still pretty consistent though. It's the same distance, but it is longer than that normal interval. If you have longer that drop, then you have a Wenckebach. That's going to be, again, if that PR interval is getting longer, and then that QRS drops, then you have that type 1. And then if some Ps don't go through, then you have a Wenckebach 2. So that one, you don't get that prolonged PR interval. Again, that PR interval is pretty consistent, but not a QRS for every PR interval. You get that drop QRS. That's a type 2 or Mobitz 2. And then if the Ps and Qs disagree, you have a third degree. Again, they're not talking to each other. They're doing their own thing, going to their own, drumming out to their own beat. That's a third degree. That's pretty classic. All right, so last question. I said this a couple of times during today's lecture. Just want to make sure that I drive this point home. But your QT prolongation predisposes an individual to what arrhythmia? I want you to answer in the chat. I love the participation. Thank you, guys. Mandeep, Mary, always ready to help. All right. So you guys are absolutely right. It's torsades. And again, hopefully not something you're seeing in clinical practice, but something they definitely want you to be looking out for when you're looking at your 12 leads. Is there a prolonged QT interval? Is it caused by a medication that the patient's on? Do you need to change their medication? We want to make sure we avoid a dangerous arrhythmia, a ventricular tachycardia like torsades. So definitely something that you might see come up on the boards. All right, so now with just a few minutes left, we're going to open it up to some Q&A. I'm going to leave this slide open so you can make sure that you scan this QR code to sign up for all our future webinars. Again, these are our free live webinars. We do a couple a week on different topics. This week we had part 1 of cardiology. Brittany did that on Monday. She talked about hyperlipidemia and hypertension. Today we talked about EKGs. Next week we have 3 awesome live webinars coming up for you. So if you register that QR code, you won't miss any of the lives. And if you can join us, that's awesome. We also want to point out that we have another 3-day live review. So we had one at the end of May come up and it was successful. So again, it's a 3-day live review. We hit all the highlights that you have to know for the boards. It's just $50 and it includes all 3 days, and you have about 30 days to go back and look at the recordings. So even if you can't attend live, if you register, you'll get all those recordings and you can go through it on your own time and watch the recordings. So I highly encourage you to sign up for one of our 3-day lives. The next one coming up is July 19th, the weekend of July 19th through the 21st. And again, you don't have to be live. If you are live, it's great because you can ask questions on the spot. But if you can't be live, you get those recordings for 30 days. So it really does help you prepare for your boards. And then we have our awesome Q bank. Some of the questions I pulled today in our lecture are from our Q bank. You can try it for 30 days for free if you haven't tried it already. But again, I highly recommend it because we have over 1,500 questions in there. And the best way to really assess whether you're ready or not for your boards is just to run through as many practice exam questions as possible. You learn a lot through the rationales as well. So practice. Our Q bank really gets you prepared for your board. So we're here for you. Follow us on social media, see awesome, all our awesome events coming up. You can always email us directly if you have any questions about our product line. If you're looking for something, you need one-on-one tutoring and you don't know how to sign up for that. You have a question about the 3-day live or something's going on with the Q bank, or you have questions about the Q bank, anything, you can always email us directly, but definitely follow us on social because then you can see all the awesome free and product launches that we have coming up this summer and into this fall. And now I'm going to check the chat and see how you guys are doing with questions. So Mandeep asked, are you able to host a webinar on non-clinical questions? I just took the readiness and there were a lot of questions on the nursing theories that confused me. So that's very very good question. Rachel put the answer in the chat, but I'll go ahead and read it for everyone. So Rachel pointed out that we do cover this extensively in our 3-day live review. So we do have a professional role webinar coming up in our 3-day live. Yes, you're going to see these questions on the boards as well. Again, either join us for our 3-day live. We do on day 3 go extensively through the non-clinical questions. We also have a lot of those questions in our Q bank. So when you're going through the Q bank, you can filter your questions based on certain topics, and you can just filter it to the non-clinical questions so you get a little bit more familiar with what they're going to ask on the boards in terms of the nursing theory and the non-clinical questions. But great question. Yes, so Mandeep then asked, it will also be nice to host a webinar just on questions, as it will be in the boards and explain rationale behind each question with tips for exam. It will be very helpful. That is great, Mandeep. Actually, in July, before our 3-day live, I will be doing a free weekly webinar on the non-clinical questions on the professional role. So you can, again, sign up, make sure you register the QR code just to see all our live free coming up. We haven't posted the July one yet. That's why you probably haven't seen that on our schedule, but it will be coming up. But again, it's also available in our 3-day live review. And yes, Rachel pointed out that we also offer tutoring, which is a really great way to go through those rationales as well. So we do one-on-one tutoring with myself and our other family nurse practitioner colleagues who are very experienced, and they're the ones that also do the lectures and put together the content. So if you want to do the one-on-one tutoring, we can come up with a personalized study plan for you, as well as go through the rationales that you're not understanding or getting right or not feeling comfortable with. And so that way you can feel a little bit more prepared in that section for the boards. So great question. Any other questions? And just out of curiosity, how are people feeling about EKGs? Are you feeling confident? Is there anything else that you want me to include in the next EKG lecture? Please put that in the chat. I'd love to hear feedback and make sure that we're providing you with what you need. So this is really a time for you to tell us what's working, what's not working, and how can we give you more content, or is the content awesome? You're feeling more confident? Just give us a little feedback. And Argentina asked, are we able to see this recording again? And as Rachel answered, yes. So these recordings are all available on YouTube. So if you go ahead and search on YouTube Archer Review, and you can put in EKG as well, it'll come up. So this free webinar, as well as all our free webinars, are available on YouTube. So you can go back and look at the recordings. Oh, thank you, Mandy. That's a very sweet comment. I appreciate that. I'm so glad you're able to join us for our free live webinars. I've seen your name a couple times, so it's nice to see some familiar faces, and I really enjoy the participation. So that's great. Oh, thank you, Carla. You guys are so sweet. I'm so glad you guys are finding it useful. I really like to try to break it down and not memorize, but help you understand what you're seeing, because unfortunately in clinical practice, it's not going to be multiple choice. All right. Well, if there are no other questions, I think we'll go ahead and wrap up today's lecture. Thank you again for joining us. Again, we have 3 live webinars coming up next week, so feel free to join us for those. And thank you again for all your participation today, and we'll see you next time.